the science of weight loss encompasses a comprehensive understanding of metabolism, caloric balance, the role of physical activity, and sometimes medication. Journey to Wellness, the science of weight loss. Tonight, On Call with the Prairie Doc. Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Sanford Health, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health.
Good evening and welcome to On Call with the Prairie Doc. I'm Dr. Kelly Evans-Hullinger, your volunteer Prairie Doc for this evening's program. Tonight we are discussing weight loss and answering your questions throughout the show. Weight loss should be approached as a gradual process with the primary goal being sustainable changes to diet and exercise rather than quick fixes or extreme diets. It's essential to understand that individual factors such as metabolism, genetics, and medical conditions can significantly influence weight loss progress, so what works for one person may not work for another. Achieving sustainable weight loss involves a balanced approach that includes nutritious eating, regular physical activity, behavioral changes, and sometimes medication or even surgery. Regular check-ins with a healthcare provider can help monitor progress, ensure nutritional needs are being met, and adjust any weight loss plans safely, minimizing the risk of negative health effects. In the studio this evening are Dr. Zolio Lansang from Avera Medical Group Comprehensive Weight Management, Dr. Jennifer Schriever from Sanford Weight Management Center, and Dr. Megan Hegyi with Sanford Harrisburg Clinic. Thank you all for being here with us tonight. We appreciate it. Dr. Hegyi, tell us a little bit about your practice and what brought you to weight management as an interest.
Absolutely. So I am trained in family medicine, and so I split my time between my Harrisburg clinic as well as the weight management center. And I became interested in obesity medicine because this is an area of growth. All areas of medicine are, but I feel like this area particularly is seeing so much new research, so much attention recently. And shortly after I started with Sanford, or really even before, I was aware that we had a specific weight management center that approached weight loss in a multidisciplinary team, and that really interested me. So that kind of steered me towards a board certification in obesity medicine. And so now I do both family practice and obesity medicine.
Great. And Dr. Lansing, you do weight management full-time now after having done primary care family medicine for a lot of years. What made you decide on that career change? Why do you enjoy doing what you do now?
Yeah, so back when I was practicing primary care, I have seen so many patients that struggle with weight. And from struggling with weight, they will have diabetes, high blood pressure, arthritis, all sort of disease related to weight. So I had this moment of like, what if I can address their weight, can I change the future of their health? So I decided to really dig into the obesity medicine. I became board certified in 2020. I started doing obesity medicine back then when I was in primary care, but you have to have a multi-team approach. So when the opportunity came in, they offered me the position at Avera, and they will support it. I grabbed the opportunity, and now we are just really hitting the ground, and we are so busy right now.
Yeah,
so, yep.
Great. And Dr. Schriever, you also do weight management full-time now, is that right, at Sanford? Tell us a little bit about the growth of that program, because you were there when that started as well, is that right?
Yeah. always been passionate about nutrition and physical fitness and health and prevention of disease, and so found the specialty myself and helped to develop the program for Sanford. You know, you create the pilot program, and we did that in 2020, and then have just half a day a week and just rapidly expanded, and to a lot of providers doing it, myself and 3 APPs, and then we have about 4 family physicians and 2 internal medicine doctors that come, and 2 pediatricians, along with our 5 dietitians and
Big
2
team.
counselors.
Yeah.
It takes a big team, and the patients appreciate it. It's very rewarding.
Yeah, great. Well, as we prepare to engage in our discussion, I want to take a brief moment to express my sincere thanks to each of our viewers. Your contributions are incredibly important every week. Each dollar you give supports science-based health education. Now let's turn our focus to you, our audience. We invite you to submit your questions for tonight's conversation on weight loss. There are 3 ways to reach us. Call us at 1-888-376-6225. Send an email to ask@prairiedoc.org, or engage with us on our Prairie Doc Facebook page. We will do our best to address as many of your questions as time allows. If we can't get to yours, we sincerely apologize. All of your questions are anonymous and no information will be saved. However, if you would like to leave your name, email, or phone number, you'll be entered into a drawing for our Prairie Doc publication, Perspectives from the Prairie. It's not a requirement to submit a question. We'll announce the winner at the end of the program. I'd kind of like to start, just talking about obesity as we view it now, and as you all view it when you're practicing with the patients that you see. How has our understanding of obesity as an entity changed from maybe 10, 15, 20 years ago? You want to start?
Absolutely.
Megan?
So we are really realizing more and more how complicated obesity as a disease is. And even doctors years ago would tell patients, just eat less and move more, and if you do that, you'll lose weight. And if you're not losing weight, you're not working hard enough, which we know just isn't true. There are so many other factors at play. Other medical conditions, comorbidities can play a role, genetics can play a role. Certainly nutrition and activity can play a role as well. But there absolutely is more at play than just what you eat and how you move your body.
Yeah, great, which I think is validating for a lot of patients who have
Absolutely.
struggled with this over the years, right?
Absolutely.
How do we do have definitions for obesity, and maybe they're problematic to some degree, but can you just give us the definitions for what obesity is and what that's based
as
on?
of this time, the most common thing that we use is BMI.
Right.
So
And what's BMI?
BMI is body mass index.
Yeah.
So that is a ratio of your height and your weight, and there's a graph. If you are above 30, you are classified as having obesity. If you are between somewhere between 25 and 29, you're overweight. So right now, as of this time, we're still using BMI to catch all those, but is it 100% accurate? Not really. So we have to consider that, in the next few years down the road, that this is just a screening tool, and then we're going to add some more details so that we can really identify the patient as a patient having obesity.
Yeah, good. So BMI is nice because it's simple, right?
Yep.
I can get it with when my patient's weight and vital signs. What are the problems with BMI, or where do you see that not representing accurately obesity, Dr. Schriever?
Sure. Really, on a population level, it can be helpful to assess your population's health, but on an individual, like you're alluding to, it's not. It really matters how much muscle mass, or how much their lean tissue weighs. We look at bones, muscles, and organs versus how much body fat they have. So depending on your genetics and the life you've lived, you might have a fair amount of muscle mass, and so your weight is going to be higher, and maybe have less body fat contributing to that weight and the BMI calculation. But otherwise, on the other end of the spectrum, you might naturally have low muscle mass or have lived a life that didn't naturally build that, and as you get older, you lose muscle mass. And so then that body composition of that ratio is much more important than what the scale tells you.
Yeah, so probably room for improvement. Maybe in the future we'll have easier tools to assess that. Okay. Well, Dr. Jennifer Schriever is a family physician at Sanford Health who focuses on full-time weight management. Prairie Doc spoke with Dr. Schriever separately about her insight into creating a sustainable weight management plan.
Schriever says they start by doing a complete evaluation of the patient, which includes a full medical history and even social history lifestyle of how they are currently living.
Because all of that matters. Our program is here to help create a lifestyle that leads to weight loss and improved metabolic health, which isn't just about the scale, but also that makes it sustainable.
She adds that they look at the 4 pillars of obesity medicine, which are nutrition, physical activity, behavior, and medications.
So it's really about developing a lifestyle that works, not a short-term diet that will lead to weight loss. Rapid weight loss will lead to too much muscle mass loss, and if muscle is responsible for a significant portion of how many calories you burn in a day, if you lose a lot of muscle as part of your weight loss, then that makes that weight loss difficult to sustain and easier to gain weight back.
Schriever says that the patients in the program check in every 6 to 8 weeks because it really is about making a lifestyle change.
It does help to check in frequently because this is a lot to learn. Our education about nutrition and physical activity has not been great throughout most of our lives, nor having a clear understanding or how your body responds, because everybody's a little bit different. So we kind of need to tweak it and help it adjust. And life happens. So life makes a lot of those decisions and our lifestyle difficult. So how do we work around and through those things?
Great, thanks for doing that for us. A good introduction. I'm going to get to some viewer questions, and I'm noticing we have a couple about diet and nutrition, which is a great place to start when we're talking about weight loss, right? So let's get to those. We had an email question, Dr. Hegyi. I've been having trouble losing weight, and my doctor recommended tracking food intake. Is this necessary? I don't eat a lot of junk food. What do you think about food tracking? And I guess what do your nutritionists in your clinic tell people about that?
This is a great question that comes up all the time, and this, like many things in the weight loss journey, is really dependent on the person. I will say there can be a lot of insight that's gained with food tracking, and there are a ton of apps out there. Some of them are really helpful, some of them are too in-depth, and people can get really caught up in the numbers with those. Sometimes what we have folks do is just pen and paper, just what are you eating and about what amounts, and this also doesn't have to be something that you do for the rest of your life.
Sure.
But especially if we're trying to identify maybe what are some areas that we can tweak or improve, tracking can provide some great insight, even if that's even for a few weeks, so that we can say, what really are we taking in? Because it is hard sometimes to remember. All of us do this, where we can look back and say, no, I really think, this was going pretty well, and we forget about things here and there. So it can help to open our eyes to that and also allow us, ways to identify room for improvement. With that being said, I know for some people, it can be detrimental at some times because we can get really obsessive or in our head about the data and about the numbers. So I think it has to be individualized, but as a tool, it's often helpful.
Dr. Lansang, do you find that are there common things that your patients discover when they're first meeting with a nutritionist, maybe that first consult or two in your clinic, that are common things that people find that they didn't know were unhealthy that they were doing, that they're discovering? What are some common things that would be low-hanging fruit?
Yeah, exactly. Some of our patients, sometimes they will eat a healthy food, but they will eat a ton of that.
Sure.
So at the end of the day, they're consuming so much calorie. I have one particular patient, she likes to eat candies, and then after seeing me, after talking to me, she started eating fruits. And then when she followed up, she didn't lose weight, and I asked her, what are you doing? So she told me no, I'm not eating candy, but I'm eating pears, I'm eating apples. And then I asked her, how much do you eat? And she kind of paused. And she told me, I eat a lot. So one of the things that I always tell my patient, one is you need to bring down your caloric intake. That's number one. Number two, you need to change the characteristic of the food. You make sure that they are mainly, for me, I always emphasize the plant-based nutrition, and at the same time making sure you don't eat so much of the healthy food, because sometimes they tend to eat, at the end of the day they're consuming so much calorie too. So,
Okay.
yep.
Just portions.
Yep.
Okay. We had another great question. Why are so many fad diets often unsuccessful in the long term, despite promising and sometimes having fast results? I imagine you've had a lot of patients who've lost weight and gained it back on fad diets. Why does this happen, Dr. Schriever?
Sure. And a lot of the fad diets really aren't sustainable. So you really have to approach weight loss with something that you can continue to live with and develop and change gradually, rather than a sudden weight loss. Also, as we lose weight, we lose water, fat, and muscle. And if you lose weight rapidly and not in a good fashion, you're going to lose a large portion of that weight is going to be in muscle. And most people, we really aren't aware of that, but muscle is responsible for a significant portion of how many calories you burn in a day. So not only as you lose weight, if you lose muscle, you're losing that calorie burning tissue, but you're also losing weight. So it does take less energy, less calorie burn to move yourself around. So it's multifactorial too in that process.
Yeah. Good. And it's common for those diets not work long term. That is not a failure on your part if that's happened to you, for sure. Another dietary question. We had a caller that asks, they eat gluten-free but are struggling to lose weight. Is there anything about the gluten-free diet that makes it more difficult to lose weight? Is that something that you've seen at all?
Yeah, absolutely.
Yeah.
This kind of gluten-free has been something that's become more and more common as people are kind of more aware of it. And the good and the bad part of that is that there's a lot more gluten-free options out there now. So it's nice because it does give folks some more options. The hard thing is just because it's gluten-free doesn't necessarily mean that it's healthy. And so, and this is true with any health food, is that it can be marketed in that way, but it does not mean that it's healthy. And so instead of just looking at, is this gluten-free, the important thing is looking at what still is the nutrition of that. How processed is it? What's the sugar content of it? Conversely, how much maybe protein or nutrition does it have in it? So that would be something I would look at, is what is the nutrition beyond just does it have gluten in it?
Yeah, good. Another dietary question, we had a Facebook question. Do I need to change my diet as I age to maintain my weight? How does age affect our ability to kind of keep our muscle mass and weight the same? What do you see in your aging patients?
So I have a lot of patients who are on the geriatric age group. So the first thing I always tell them, there is a natural tendency of the body metabolism to slow down no matter what you build. So I always tell them, as you get older, it's hard to lose weight, especially one, they are not active. Number two, the food that they're eating is the same, so they need to adjust it based on the age. So when you look at it, if you want to maintain your weight as you get older, in fact, you need to be more active and try to be more mindful on your caloric intake in the food that you're eating. So every time that I see a patient on geriatric age group, I become a little bit more on the geriatric mindset and have a different approach when I'm seeing other age groups. So,
yeah. Good. And I find maybe the goals change too. Maybe we need to focus on function a little bit more than the weight on the scale in those situations too. Good. Another sort of lifestyle question. We had a caller ask, my doctor recommends I weight train to lose weight. How does this help? Shouldn't it just be cardio? We're learning a lot more about this, and this is changing a little bit. What do you tell patients about exercise and trying to balance the different types of exercise?
Sure. Well, the main thing with exercise is to make sure you're maintaining your muscle health. Speaking of the geriatric population, we do lose muscle with age, and that age can even start slowly at age 30. So the more you maintain that muscle health, the more you maintain your metabolism, and then your weight loss is more sustainable. Also, you'll live longer, healthier if you're strong enough to prevent those falls. And muscle really helps you prevent diseases too, because it's helping you burn those calories that otherwise might, cause some inflammation and put you at higher risk for disease. So strength training is really important. Of course, we need some level of cardio to, improve our heart health. And we'll talk about, based on body composition scales, learning more about visceral fat. So we have fat we can kind of see under our skin and feel, but visceral fat is internal. And that really takes some exercise, and probably the higher intensity exercise is more effective at losing that fatty tissue, which we really care about more metabolically than the other fatty tissue you might be able to see easier.
Yeah. So, I mean, a lot of our patients that maybe are coming to us struggling with weight might be starting from not being very active, and maybe that's just how their life's been, and maybe their weight's kept them from being active. How do you coach that new patient on starting an exercise program? Where do we start with this?
Yes. Start small.
Yeah.
That really is the case for any changes that we're making. If we want to make this sustainable, the way not to do that is to try to make these big changes and change everything all at once. And so that's why often when I work with patients, I'll say, let's focus on one or two things maybe at a time. And exercise is a great place to start, but especially if we are not used to doing much activity at all, start small. 10 minutes is better than nothing. And once we kind of start to ingrain that habit and make movement a few days a week easier, even if it's just 10 minutes at a time, we can build on that. So start small and start with doing something that you like or that is at least tolerable to you.
Yeah.
There are absolutely people out there who love to exercise. A lot of people don't feel that way. It's not the first thing that they would want to do with their free time. So start with something that at least you feel like is not as burdensome as something else. Not everybody has to be a runner. Not everybody has to do the elliptical or the stair stepper. Find what works for you.
Yeah. Do you have other tips that have worked for your patients?
Yeah,
with starting exercise?
Yeah, exactly. So sometimes I will tell my patient, what can you do for me by just walking? If you can walk, how much can you walk? From that baseline of, let's say, 10 minutes a day, next follow-up, we're gonna try to increase it. So anything that they can do with their function at the same time that we can improve on, something that we can start from the baseline. I don't usually try to do this, and do that. So it's basically important is enjoyment of doing what kind of exercise they're doing. So.
Sustainability again, right?
Yep.
We got to be able to do this forever.
Yep.
Good. Well, we'd certainly have some questions about medical treatment of obesity. So let's talk a little bit about that. I think our viewers probably have a lot more knowledge maybe than a couple of years ago about medications, in particular the class of medications like the injectables. There's a few names for them. How did the medications like, let's say, semaglutide, liraglutide, tirzepatide are the generic names, which of course I used to use. People might know those by Ozempic would be a common one, or some other names. How do they work? How do they help people lose weight?
Sure. So those medicines are made to mimic or be the same as fullness hormones. So they're GI tract hormones. We often don't think of having hormones beyond female or male hormones, but we have lots of hormones in our body. And those hormones have a lot of responsibility. The medications last a whole lot longer than our natural fullness hormones. So they're gonna slow your stomach from emptying, so you feel full sooner and faster. They also have an effect on the brain to help with food thoughts and food noise and give you that fullness and satisfaction as well. And they also are involved in like insulin metabolism, blood sugar metabolism, so they improve your management of the calories or the blood sugar you take in and fats for the better to assist you in weight loss as well.
So a few different mechanisms that all kind of work differently. What are the most common side effects of those types of weight loss medications? Dr. Hegyi?
I'd say the most common side effects really are related to the way that they work.
Yeah.
So because they slow down digestion, which helps you feel fuller, the most common side effects are going to be GI related. So nausea, upset stomach, constipation, or diarrhea are common. We tend to see things a little bit more on the constipation side of things. And that's why we start at a low dose if we're going to start one of these medications, and we go slow. We titrate up slowly. And there are ways to mitigate those side effects as well, but GI is most common.
Yeah, for sure. We see that a lot, right? So we talked about kind of starting low and then increasing and setting people up for success that way. We did have a caller ask, once I get on a weight loss medication, do I have to take them forever, and is that okay? What do you tell people when you're counseling them about initiating a medication like this?
That's a very good question.
Yeah.
And I try to be honest with my patient, but I go back to tell them what is obesity. I always tell them that obesity is a lifelong disease. So a lifelong disease needs a lifelong treatment. So when you look at it, if we start on medication, I always tell them, you have to take this for quite a long time. Because the moment you stop this medication, the chances of you getting back to close to your previous weight is likely. So just imagine if a medication helps you not to be hungry, helps you to feel full faster, you take away that medication, everything comes back because that's our biology. So
Yeah.
I-
What do you add?
I also see that, you know, for patients, given enough time, I mean, certainly we should not feel ashamed to take it for weight maintenance. Absolutely not. But for patients who desire, I mean, just like you can improve your diabetes or your blood pressure and work off those, for patients that are really adapt the lifestyle and enjoy how they feel with the nutrition changes and the exercise, and they really appreciate that and adapt to that, then they can slowly wean off and learn to naturally manage hunger or the food thoughts or food noise. They might do okay, and I think we're collecting real world data that actually shows that they aren't necessarily going to gain the weight back. But unfortunately, it's not a cure and then it's over. It does take lifestyle changes that we aren't used to necessarily doing. And I think it also depends on the food, the disordered eating you might have, emotional eating or stress eating, and where did that come from and how much trauma do you have around that? I think for those people, I mean, like I said, we shouldn't expect them to go off of it, but maybe they might find benefit from it longer.
Yeah, good. Do we have good data about the safety long term about these medications? What do we know about long term use?
Right, so these newer medications, they are newer in the weight loss space, but they have been around a lot longer for the treatment of diabetes. And people might not realize that our safety data goes back many years because folks who have diabetes have used these long term and they don't go off the medication. And so we know that they are safe long term, and so people who need them and can benefit from them long term should know that they can safely do that.
Yeah, good. We got a new question. I'm going to direct this to you, Dr. Schriever, because you were just talking about your kind of prior life in obstetrics. A caller asked, do GLP-1s and other weight loss medications have contraindications for pregnant women or any effect on fertility?
So generally we don't continue medications in pregnancy because, I mean, the goal of pregnancy is not weight loss. There doesn't appear to be necessarily any risk of birth defects or anything if you do happen to get pregnant on these medications. They do have evidence that they help improve fertility. Certainly weight loss helps. It can help in a multitude of ways from, you know, how female hormones are functioning to maybe inflammation disrupting their fertility. There's also building evidence that women on these medications prior to pregnancy will have a healthier pregnancy and are at less risk for complications, including like preeclampsia and of course gestational diabetes, but there's building evidence for that. So, you know, of course the societies or from those pregnancy specialties will say, you know, you should go off of that if you're trying to conceive. For a few months, my experience has been some providers do want the patients off, especially going through maybe reproductive and endocrinology treatment, but some of them will just, well, if they get pregnant, tell them to stop. So,
but really, if you're thinking more about future pregnancy instead of in the very near term, actually might improve your pregnancy outcomes or some building evidence about that.
The medication itself, as well as having an improved weight.
Great. Good. There's a great question that just came in from a caller. What are the biggest misconceptions about weight loss that you encounter in the clinic? And, you know, in your guys' clinic, you're encountering patients who probably, this is not the first time they've tried to lose weight, right? This is something that has been a challenge for them probably for a long time. So what misconceptions do you see in your patients that you're trying to coach them through?
I think one of the misconceptions that so many patients who come to us have experienced before is that this is my fault, that I can't lose the weight, that this is a personal failing. I'm just not working hard enough, I'm not doing the right things. Where, as we talked about earlier in the show, it's so much more complicated than that. So that's one of those things that I talk to all of my patients about, that it's not your fault that you have maybe been unsuccessful with weight loss in the past, or that you have tried and gained the weight back. The other thing is that, well, there must be just one right answer that I just haven't found yet, when in reality, with everybody, there's an element of experimentation. Everybody's body responds differently, and so that's why we see patients back regularly, so we can find what worked, what didn't, what do we need to change, what is your body going to respond to.
Yeah, good. Do you guys have anything to add to the misconceptions that you?
So a lot of my patients sometimes will get frustrated because they are trying their best to exercise and they don't lose weight.
Right.
So I always tell them, when you exercise, don't expect to lose significant amount of weight, because it's not really what it meant to. Because when you exercise, I always tell them that is a maintainer, but the number one driver of weight loss is actually our nutrition. So I always emphasize nutrition, and obviously we always have to emphasize physical activity. So.
Yeah. And I always frame that physical activity has so many benefits besides the weight loss, to make sure we're focusing on that as well. Great. Well, weight loss surgery isn't a quick fix, but it can be used as a tool to help patients achieve a healthier lifestyle. Prairie Doc spoke with Avera about bariatric surgery and how losing weight can improve your overall health.
Gina Melhoff is finding things in life a lot easier after losing over 100 pounds.
I'm down like 130 pounds from my highest. Any kind of exercise is way easier. Any kind of travel is way easier. You know, everything is easier. Even going up a flight of stairs is way easier. Life in general.
Her successful weight loss is thanks to bariatric surgery. After discussing with her primary care physician, she decided it was a journey she wanted to take.
We had talked about weight loss surgery off and on, and I didn't know if I wanted to go down that route. So then I'm like, okay, maybe I need to have those conversations, start meeting with the team. I've always heard great things, and so I'm like, let's make an appointment. Let's kind of find out a little bit more about what the journey is, what it entails, what are options, what are things that are going to work for me specifically, and so I started.
There are different options when it comes to weight loss surgery, including surgical and non-surgical. The team at Avera can help patients decide which option might work best for them.
And we have a whole medical team with Avera called Comprehensive Weight Loss Management. And that team has a board-certified bariatric doctor and some nurse practitioners that help take care of patients pre-surgery, post-surgery, and sometimes the patients that are in between that aren't sure if they want surgery. So it's really a team approach.
For Gina, she had gastric bypass surgery.
About 35% of the surgical procedures are the Roux-en-Y gastric bypass, also done robotically or laparoscopically, and those people spend about one night in the hospital typically. And the surgical procedures are really the two mainstay in America right now, the United States, the world, our clinic. The sleeve is a case that we do minimally invasive. They're typically outpatient procedures for the sleeve. You remove about 80% of the stomach.
I went home that next day. And then it was just adapting to the new lifestyle, making sure you're trying to get your calories, pushing your fluids.
Weight loss surgery isn't a quick fix, but can be used as a tool to help patients achieve a healthier lifestyle.
You have to use the tool appropriately. If you listen to your body and use the tool, which is that you feel restricted with a little bit of food, you're going to do well. And it's a major transition of eating slower, chewing your food, taking your time, and eating less.
While Gina has lost weight, she has gained better health.
It's a full team effort with your physicians, with your dietitians. The nurse practitioners are amazing too. So have the meeting. It's your health, and it's something that it's going to affect everything.
Thanks to Dr. Thamert and his patient for that roll-in. So I imagine you probably see patients maybe before or even after bariatric surgery in your clinics as well. Let's say you're maybe referring someone on to bariatric surgery. Can you tell us what they can expect? I mean, they're not going to go have the consult and then have surgery next week, right? So how does that program usually work, Dr. Schriever?
Yeah, I think some of that varies on their insurance, but usually it's monthly visits for I think around 6 months with their dietitian and their guidance and their following, because they have to prove that they can do that nutrition. There's also a psychological evaluation. If they haven't been diagnosed with sleep apnea, there might be a sleep study and some lab work to check for, vitamin deficiencies or other health concerns. For patients in our program that decide on bariatric surgery, I always tell them I'm happy to support you along the way. If medications are a part of your program, you should stick with us because they aren't comfortable with those, and we're happy to see you afterwards and support you on that journey too.
Yeah. Because people can continue their medications or go back on medications after bariatric surgery, correct? Great. Do we see different success rates with bariatric surgery compared to our medicines? What do we know about that comparison at this point? Yeah.
Right now, when you look at the advent or the introduction of GLP-1, we can see some of the very successful GLP-1 patients are actually equivalent to surgical. I mean, I've been seeing that in my practice, and I tell them that every time that we see those numbers, we always kind of tell them that you have to maintain your lifestyle. The same is true when you have surgery. If you started slipping up on your lifestyle, you're still gonna regain. So the advent of GLP-1 is really making a game changer right now. So yeah.
Yeah, neither is 100% successful either, right? What are some risks of bariatric surgery? What might make a patient not choose bariatric surgery that you've seen?
Right, well, it is a major surgical procedure, and so that's absolutely something to think about. Is there's risks with this procedure itself, there's risks with the anesthesia. There is also a lot to think about after bariatric surgery. So there is a very strict diet or nutrition protocol that they have to follow. There are risks with certain vitamin or mineral deficiencies, and so keeping up on the recommended nutrition as well as the vitamins, that is something that you have to think about lifelong. And then, like we mentioned too, there is a risk of weight regain after, just like with any other weight loss tool or weight loss program. And so being really diligent about those lifestyle measures, like Dr. Lansang had mentioned, is important.
Great. In our last 15 minutes or so, I'm just going to kind of run through questions. We'll see how many we can get through here. We had an email question early. How does one minimize the flabby or crepey skin accompanying weight loss? So what do you see with some of those cosmetic things with a high percentage of weight loss, I guess, and how do you help patients deal with that?
Sure. Unfortunately, skin doesn't resolve with weight loss over time. So, there's all sorts of tools as far as powders or creams to help with rashes that develop in those skin folds. But really, most of the time, if it's significant weight loss and significant issues with the skin and infection, then it is skin removal surgery.
Yeah.
I mean, there's a few creams that might help it look a little smoother. Having good muscle tone will help to some extent, but most of the time when it's significant, it's plastic surgery.
Working with your plastic surgery team, right? Yeah, great. We had an email question. Dr. Lansang, my thyroid was removed about 12 years ago. As a result, my weight has increased with my metabolism. I exercise and watch what I eat, but how can I reduce my weight? We'll assume this person's on thyroid medications and has lab results that are normal. But what advice would you give this person?
So for those patients who have thyroidectomy or removal of thyroid, as long as their labs are appropriate, most often than not, it's usually something else.
Sure.
Is it your lifestyle? Is it your eating? Is it your nutrition? When I used to be in primary care and anybody who's dealing with weight, they always want to ask me, can you check my thyroid? Can you check my thyroid? 90% of the time, they have normal thyroid.
Sure.
So,
yeah. So focus on all the other stuff we've been talking about, right? Good. We had a Facebook question. I struggle to lose weight and I feel down when I hit a plateau. What else should I be doing? So how do you coach patients through those times where they've been successful, now they've kind of plateaued off, or maybe they even regained some weight? How do we get through those challenging times?
First, I tell patients this is part of the process.
Yeah.
I have not met anybody who has gone through their weight loss journey and never had a plateau or never had a period where they gained a little bit of weight back. And very common that, again, we kind of personalize that and it feels like a failing, but it really is just part of the process. And so often that can be a sign that our body has gotten really comfortable with whatever changes that we're making. The body likes to adapt and then get comfortable where we're at. And so often it just means there's maybe something that we can do a little bit differently. Is it adding in a little bit more strength training? Is it tweaking nutrition a little bit? If they're on medications, does that mean we need to adjust the medications? That's just a sign that the body has gotten comfortable and we've got to keep it guessing.
Yeah, great. Don't get too frustrated. Okay, we had a caller ask, this is an interesting one. I had my gallbladder removed and have put on weight even though I didn't change diet or exercise at all. Does the gallbladder have anything to do with the way my body's processing food? I don't know that I've seen that. Yeah.
You know, certainly the gallbladder helps with function and food digestion to some extent, I guess. I can't remember exactly all that's involved, but that really isn't, you know, going to affect weight management. You know, certainly in the short term, the stress of that event and, you know, some swelling or fluid retention you can have around it could be, but it's maybe just a sign that the weight was maybe going to happen anyway, or it triggered something else that we just need to take a look at lifestyle and everything that's going on.
Maybe a coincidence. Okay, we had a caller ask, is there anyone that cannot be on weight loss drugs? Are there any complete contraindications to these medications?
So there are different or several types of weight loss medication. Each has their own indication and each has their own contraindication. The most popular one, everybody that they're looking at are the GLP-1 injectables. So those patients who have a family history of medullary thyroid carcinoma, have an allergy, who already have a slow stomach, we call it gastroparesis, they are not a good candidate for GLP-1. So every specific medication has its own contraindication.
Yeah, good. And that's one that we see on the drug ads, the medullary thyroid cancer. Is this something that the common person should be worried about? This is a really rare cancer, right?
Yeah. So the medullary thyroid carcinoma is very rare, and when they were doing study on this medication, they found it on rats, which is, just like Dr. Schriever was saying, is very rare to see this type of cancer.
Yeah. For most people, probably not on the top of our list of concerns, right? Okay. Let's see, we have an email question. What type of weight loss program is suggested for an active 73-year-old postmenopausal person dealing with low thyroid function? So I mean, a lot of our patients, it's just not just obesity, right? They have multiple things. So I guess how would you approach that patient in your clinic?
Yeah, absolutely. I think just like we would approach weight loss with anybody else, it's absolutely individualized to that person and what their goals are. How active they are already plays a role, what their nutrition is like already, and like we've touched on before, what their comorbidities are or what other medical conditions they have. That might influence how we coach them in certain activities or medication or nutrition. Specifically, like we've talked about before with the thyroid, making sure that those thyroid levels are in the normal range is going to be important, because if they're outside of that range, that can absolutely influence weight loss. But once they are in that normal range, then we still go back to our cornerstones. What is nutrition? What is activity? How can we stay active, especially as we get older? Like we've talked about, how can we maybe add in some strength training or maintain or build that muscle mass?
Great. This is a great question. A caller asked, they are seeing so much social media buzz for the menopausal woman regarding cortisol and insulin resistance. I do feel like cortisol is a very much a buzzword out there right now, and how that contributes to weight gain. Is this a concern? And surely you've had patients ask you about their cortisol, checking my cortisol or whatever it is. What do you tell people?
Yeah, so cortisol is such it's a stress hormone, right? And so we know that in times of stress, our levels might be elevated, but elevated within a normal range, not a true disease state. And cortisol in that process probably interrupts the insulin and how we metabolize food, and our body is going to be trying to protect itself from the stress. And so it's going to fight your efforts on weight loss. Now, there's also, as you go through they asked about menopause, right? The process of menopause. So I talked earlier about how you lose muscle at 30. For females, your female hormones do support your muscle mass, and those can start to decline at 35. So if your muscle mass is declining for whatever reason, you can have fatty tissue infiltration, and insulin resistance actually starts there. So maybe women are at higher risk for these things, having that hormonal change in midlife. Complicating, and then life is kind of stressful for a lot of midlife women. They might be in the sandwich. They're still taking care of kids, and now they're helping take care of their parents. So, or they're still working full time while, you know, trying to do everything else. So it isn't really a disease state. It's kind of like a buzzword, or there is some validity to it, but a cortisol level isn't going to help you through that. It's all the lifestyle change, focusing on stress reduction, getting enough sleep. Maybe some supplements do truly help if you want to try them, but, you know.
Okay, good. And I mean, we talked earlier, and I remember you saying something about everything in your life can affect your weight, right? And this is, we're talking about stress and sleep, and that probably relates to this cortisol question, which again is just more of a life thing. How do, in your clinics, how do you help patients through that? I mean, yeah, it's hard to lose weight and focus on all these healthy lifestyle things when you're working multiple jobs, or you've got a kid with an illness, or whatever is going on in life. How do we help deal with that?
I think that's the most important thing when you have an actual comprehensive weight loss program, just like Sanford and Avera, because you have a team to help individual on different aspect of their weight loss journey. You have a dietitian to help them meal prep. You have a behavioral therapist to help them with stress. You have a exercise physiologist that can help them with exercise. So that is the reason why a multi-component clinic is very successful, because each and everyone has a role. So,
And I'm not part of a multidisciplinary clinic, but I have multiple times really recommended that my patients struggling with this see a counselor or therapist to work on some of those, you know, life-altering things that are really affecting their health too. We had a caller ask, how do patients get referred to your multidisciplinary clinic, and how often are you meeting with patients about these lifestyle changes?
Absolutely. So we take referrals from really any physician. So it could be their primary care physician, it could be one of the specialists that they might be seeing. We also have people self-refer. So if they're interested in that, they don't have to get a referral from a physician. They can just call the clinic and say they want to schedule a consult. So what that looks like then, the process is that they will be scheduled for an initial consultation with one of our providers, as well as with a dietitian. That will be a longer visit where we talk about their history, what their experience with weight loss has been like in the past. We do a little bit of education on the general things we recommend, and get an individualized treatment plan for them going forward. After that, the follow-up really is individualized to the person. We would love to see patients every 1 to 3 months, but at least for me, I make that decision with my patients. If we are really early on in the process, or maybe we're changing a lot of things about the plan, I might see them sooner for follow-up. And if things are pretty stable and it's going well and we're just kind of continuing on with the plan, then we might space out those visits.
Okay, great. A great question came in, because I feel like I deal with this every day. I can't imagine how often you guys are. We had a caller ask, my insurance will not pay for the weight loss drugs even though my doctor prescribed it. Is there anything I can do to get them to pay for it? The insurance said the weight was not that bad. So I guess there's maybe a multitude of reasons insurance wouldn't pay, but I mean, really common. What are we seeing with insurance coverage, and are there any workarounds for that?
So as far as weight management, and insurance will cover weight management or it won't. It's kind of like almost a separate package. So if they don't, there's probably no appeal just based on weight that it's going to happen. As these medications are FDA approved for indications like reduction of heart disease or stroke or sleep apnea, or the latest is liver disease, then insurance companies still get to decide if they're going to cover it for that indication. So Thankfully, if Medicare starts to cover it, then you get more private insurances considering that. So if you're going to consider advocacy, you kind of want to start with your government, whether it's federal or state, to influence coverage. But yeah, otherwise, I mean, often it's a struggle, and the appeals and the prior auths are difficult.
Yeah, it
or
can
not,
be really frustrating.
sometimes unfortunately not worth doing.
Right. We see some patients kind of going outside the system then, and maybe getting drug from a compounded pharmacy, not as opposed to an FDA-approved product. What would you tell patients about that if they asked you that question?
So that's a good question because, you know, especially with the advent of social media, everybody is looking towards, you know, acquiring this kind of medication, and there's a lot of black market, and now it's not just a black market of GLP-1, it's even commercialized direct to consumer.
Right.
So when a patient decided that they want to do compounded, I always tell them, you have to do your research. And whatever is the complication for that, FDA will not guarantee anything. So I always tell the patient, you have to be careful on who you get your GLP-1 because there are so many things that are going right now. Type in Google GLP-1, there's about 1,000 hit, and you can click and they will probably give you $99. Who knows where is it coming from?
Right.
Right? So.
Right. Yeah, you just don't know about the making of that product, the concentration. I've even had patients come in and tell me, I say, well, what dose are you taking? And I think they referred to the number of units they were taking, and I said, well, gosh, I don't even know what that means.
Right.
So yeah, use caution, and you know, I guess I don't know what advice to give people beyond that. But it is frustrating. We are seeing, you know, improvements in coverage, and like you said, if there's a separate indication, of course, diabetes or sleep apnea, sometimes we have better luck depending on the insurance. But you can look at your insurance formularies and kind of learn that before you decide on an insurance plan, if you have a choice in the matter, I guess, would be my other piece of advice. I would say also, there's, just before we wrap up here, we've talked a lot about GLP-1s, but there are a few other medications out there, right? Oral medications that are less expensive, and that's maybe not what people are seeking, but certainly an option for some patients, right? Yeah, good. Well, our winner tonight is Nancy. A book will be sent to you shortly. We'll be back after this.
My name is Dr. Tom Dean, and I serve on the Healing Words Foundation Board, the nonprofit organization that runs Prairie Doc programming. Our mission is to enhance health and diminish suffering by communicating useful, science-based information respectfully and compassionately. Your donation supporting Prairie Doc programming makes an extraordinary difference. Gifts of any size enhance its impact in our state and beyond.
For 24 seasons, On Call with the Prairie Doc has been a premier source of health education. Join us as we uphold our commitment to deliver science-based health education rooted in trust. Don't miss out. Follow us on Facebook, Instagram, YouTube, and TikTok to explore the complete Prairie Doc library.
As we finish up this evening's discussion, I want to thank Dr. Lansang, Dr. Schriever, and Dr. Hegyi for sharing their expertise with our viewers tonight. And thank you to all of our viewers for tuning in tonight. We appreciate your viewership and support of our mission as we continue to provide science-based health education to everyone. Don't forget to follow us on Facebook, Instagram, YouTube, and TikTok for more information and updates. If you missed sending in a question tonight or it didn't align with our topic, send your questions to ask@prairiedoc.org to be answered on our weekly radio program, Prairie Doc Radio, Sundays at 6 a.m. and 1 p.m. on SDPB Radio. And be sure to download and subscribe to the podcast version of this show and Prairie Doc Radio, wherever podcasts can be found. Thank you for joining us for another On Call with the Prairie Doc. Until next time, as our founder, Dr. Holm, would say, stay healthy out there, people.
and shoulder health is vital for everyday functionalities. Pain can arise from a variety of causes, which can significantly impact daily life. Reach out. Insights into hand and shoulder wellness. Next time on Call with the Prairie Doc. Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Sanford Health, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health,